Good morning, everybody, and it's gratifying to see that at least some one of us have decided to attend our sessions on Sunday morning. The course is titled Red Flags in Oculoplastics, Identifying the Wolf in Sheep's Clothing. The course is basically designed to illustrate examples like ptosis and motility disorders, which can be presenting features of complex conditions which may be easily missed in a busy clinic. And these are the red flags that we try to raise, and the aim is to provide a comprehensive overview of potentially dangerous conditions that can present to the oculoplastic surgeon or the neuro-ophthalmologist, that can give a detailed insight into what and how to investigate these conditions. Our first talk is ptosis evaluation back to basics. Dr. Savri is on her way, and by the time she's here, I'd present my second talk, which is myasthenia gravis. Right. These are our disclosures. There's no disclosure relevant to this presentation. So myasthenia, we know, is an autoimmune condition that affects the neuromuscular junction. It is characterized by the presence of acetylcholine receptor antibodies. Now, in many cases, up to 52% of the cases of myasthenia gravis, ptosis is the most common presenting signs. And the most sensitive and specific test to diagnose the presence of myasthenia is actually a test that is available to us in the clinic, which is the eyes test. But there are a battery of other tests like the neostigmine test, the anti-acetylcholine receptor antibody, and electromyography. So when do we do which investigation? Before we jump into investigations, what we need to see is what are the red flags for myasthenia gravis. Whenever a patient with ptosis comes to you with a history of variability, which means that the ptosis is absent or much better in the morning, and ptosis worsens as the day progresses, is a red flag. Remember, this variation may not always be classical or textbook. Sometimes a patient can also present with a variation that ptosis is worse in the afternoon, but it improves in the evening. As long as there is a variation, it itself is a red flag. Apart from ptosis, if patients have complaints of diplopia, which may be occasional, which means sometimes they have diplopia and sometimes it improves, it again is a red flag. Patients who have been diagnosed previously as an unusual squint condition, and later on they've gone to a second specialist or a second opinion and they have a different squint diagnosis. So varying diagnosis from ocular motility experts is again a red flag for myasthenia. Patients who give history of difficulty in swallowing and having to take a big sip of water while having to take the food down is again a red flag for myasthenia gravis. So like we said, eyes test. Eyes test is when you place an ice pack over the ptotic eyelid for at least 2 minutes and see a 2 millimeter improvement in ptosis. This has a sensitivity of up to 92% and a specificity of 98%. You can also, it basically is a test that you can do in the OPD. Remember, for ptosis, the ice pack is placed for 2 minutes, but for ocular motility disorder, it's placed for 5 minutes. I think this is a short video that is demonstrating the ice pack test. Here we keep the ice pack for at least 2 minutes by the clock and make sure that both eyes are applied with the ice pack. Remember to always document the ptosis before placing the ice pack. And here after placing the ice pack, again the ptosis is documented. But you always have to compare. Now you can see that the patient who had severe ptosis in the left eye pre-op and moderate ptosis in the right eye pre-testing now has a near normal eyelid aperture after placing the eyes test. So this is a classical positive eyes test where a lid elevation of 2 millimeters is seen. The next is neostigmine test, which is an invasive test. It gives real-time results, which basically neostigmine is injected under the supervision of an anesthetist with all monitoring. All evidence about the diagnostic specificity of neostigmine test is from generalized myasthenia with very little evidence in ocular myasthenia. Single fiber EMG is also known to have a sensitivity of up to 95%. Anti-acetylcholine receptor antibodies is considered to be the gold standard for diagnosing myasthenia. However, it is present in only 30 to 77% of the patients with ocular myasthenia gravis. So with so many tests present, which one is the first test that you would request for a patient in myasthenia gravis? So based on your clinical suspicion, you have these tests, and the point of this study is to help you understand when do we get which one, to assess the diagnostic yield of various investigations. So this is the data that we are presenting comes from our own experience of 37 consecutive patients of myasthenia. Eyes test actually gave us a positivity of 34 out of 37 patients, which means a sensitivity of 91%. Neostigmine gave us a sensitivity of 56%. Single fiber EMG gave us a sensitivity of 59%. And anti-acetylcholine receptor antibodies gave us a sensitivity of 45%. So basically, if you line them up, you can see that the order is the eyes test, followed by single fiber EMG, followed by neostigmine, followed by anti-acetylcholine receptor antibodies. Remember, these are in patients with myasthenia who presented with unilateral ptosis. Now, how about you split them into two groups? Because the average age was 46 years, we split them into two groups, below 45 and above 45. And on comparing these two groups, we found that single fiber EMG had a significantly higher rate of positivity in those aged above 45. Which means that if a patient comes to you presenting unilateral ptosis and you suspect myasthenia, rather than doing any other test like anti-acetylcholine antibodies, you'd rather do a single fiber EMG because that has the highest chance of giving you a diagnostic yield. In our patients, the mean duration was 13 months, which is about a year. So again, we divided the patients into two groups, those with a mean duration of symptoms less than 12 months and those with more than 12 months. And in patients in whom the symptoms was for more than 12 months, neostigmine test was significantly higher, positive in a higher proportion, and anti-acetylcholine receptor antibodies was also significantly higher in that group. So if you have a patient with recent onset ptosis, you'd rather not do neostigmine test and anti-acetylcholine receptor antibodies because they have a lesser chance of giving you a diagnostic positivity. Why is this important? Because there are a lot of economic implications. Now, if you do the entire battery of all tests, which is antibodies, single fiber EMG, an eyes test, neostigmine test, it would cost you almost 20,000 Indian rupees, which makes a strong case for tailoring these investigations to maximize the diagnostic yield. So therefore, in patients who have ptosis for more than 12 months, the first line of investigation should be antibodies, followed by neostigmine tests. Excuse me. And in patients who are older than 45 and with a history of diplopia, you'd rather do a single fiber EMG before doing an antibodies. Also in patients with severe ptosis, you would do an antibody test. Of course, the caveat being that in all patients, you would do an eyes test in the clinic to already build up your diagnosis and confirm it. So therefore, apart from the eyes test, factors that should be considered while investigations patients with myasthenia are age, duration of symptoms, previous history of diplopia, and severity of ptosis. A quick note about the presence of thymoma in patients with myasthenia gravis. While thymomas are largely present in patients with generalized myasthenia, up to almost 10% of ocular myasthenia gravis patients also have thymomas. And in patients with thymomas, you have a high chance of getting acetylcholine receptor antibodies. So therefore, if you have a patient with anti-acetylcholine receptor antibodies, it may always be prudent to advise a CT chest. Patients with anti-acetylcholine receptor antibody negativity rarely have thymomas. Remember, you're not the solo treating physician of myasthenia. Treatment for myasthenia has to be in conjunction with a neurologist who at least can manage your side effects of the medication. You start off with the corticosteroids. Again, corticosteroids, unlike other disorders where it is started off in a tapering fashion, here it is in an increasingly higher dose. Again, with the help of your neurologist, immunomodulators can also be given. So, what have we learned? That there is no single test to rule out myasthenia. Investigations can only help supplant your clinical diagnosis. Ptosis and diplopia are the initial signs in over 50% of the patients. And remember, myasthenia can present at any age. This is a 2-year-old girl with left eye ptosis. The father came to us saying that the child looks sleepy all the time, has been diagnosed as left eye congenital ptosis, and was advised a tarsofrontalis sling in the left eye. So we asked the parents, has the droopy eye been there all the time? Father said, yes, always the left eye is droopy. Mother said, both eyes are always droopy, it is not the left eye. But here you can see in the photograph that the right eye looks normal. So we asked the patient to come back after a week, and lo and behold, at presentation at 1 week, both eyes were droopy. Such classical variation is a big red flag. Antibodies were positive, the CT chest showed us a thymoma. Again, this was a patient with a history of trauma, had an undisplaced lateral wall fracture with reduced vision in the left eye, came with history of diplopia and ptosis after trauma. It was diagnosed as a traumatic optic neuropathy and traumatic third nerve palsy. These are the 9-gaze motility photos. As always, we do an eyes test in all patients with motility disorders, and after the eyes test was done, suddenly the patient's ptosis and exotropia had recovered. This was actually myasthenia which was masquerading. So I think that helps us in understanding that in all patients who present with ptosis and diplopia, an eyes test in the clinic is extremely important, and always tailor your investigations so that you don't have to advise a barrage or a battery of investigations in every patient. Thank you so much. I think I'd like to invite the next speaker is Dr. Savri Desai, who's a senior consultant in oculoplastics at PD Hinduja Hospital in Mumbai. And she'll be speaking to us on the back to the basics in ptosis. What investigations and what red flags do we need to look out for while assessing any case with ptosis apart from myasthenia, I hope.
Thank you, Akshay. And I'm sorry I got late, but they've shut the roads in between for some cyclathon. So the ceiling and the road got shut for a while, so they weren't allowing any cars. What? I'm sorry, my voice is pardonable. Thanks, Akshay. So, I'm sorry about my voice, but... So I'll be speaking on ptosis evaluation back to basics. When Akshay conceived this very sort of simple IC, we actually all felt that some of these points, like what he presented, what I'm presenting, and the next few presenters are going to do, were just simple things that you sort of need to know when you're examining in the OPD. And but these are the little things that you learn as you practice often. So a red flag is like a danger signal or a warning, but often it can just be an alert, like we get in usually in our emails. So it's something that basically it means that you need to look out for something. So in evaluation of ptosis, we go through the sequence of whether there is ptosis or not, whether it's congenital or acquired, unilateral, bilateral, how acute or gradual it is, associated factors, family history, and then final choice of surgery and factors affecting surgery. What we will be going through is just mainly the evaluation. So this is kind of the chart that we do, or even the residents do in the OPD, but we'll just go through the important ones. So here are two ladies. The one on the top has what she thought initially was her eye looked big, but also that her left eye was looking smaller. Whereas this lady said that her right eye was looking smaller. So in this case, she actually has a normal left eye with a raised eyelid, which is causing eyelid retraction. And this lady had enophthalmos, because of which the eye was appearing smaller. This gentleman was complaining that his left eye looked very droopy and small, and I agree, but that's also because it's primarily a brow ptosis and nothing to do with the eyelid position, and it's getting masked because of the brow ptosis. So pseudotosis is something you should remember, whether it's the contralateral eye or the ipsilateral eye. If you look at this girl, she complained that her right eye was drooping since a couple of months, like just recently. So I said, when we looked at her and evaluated her, we found that, asked her to show her photos, she had a very similar appearance in her childhood. So basically there was a slight angle of the eyelid which was down, and this part or the tarsal show was a little less as compared, but if you see, it's exactly like what she was when she was an infant. So what often people feel is not necessarily actually a ptosis. Now this girl did give a history of some surgery and initially was being very evasive, and that she had a drooping eyelid. Of course, the scar said it all, and also that she had a lid lag. So she had 2 ptosis surgeries, and of course, sometimes the patients tell you, even if they don't tell you, you're going to be able to know, but history about a previous surgery is very important, especially if you're going to reoperate others, you're going to burn your fingers. Palpable fissure height is pretty straightforward. We need to do it in primary gaze, up gaze, and down gaze, where each one sort of gives a clue, which we'll come to. Then ptosis is classified into mild, moderate, and severe. So when you do a palpable, basically a LPS action, what do we get information when doing or measuring LPS action? Are we just measuring it just to know for surgery? So one, of course, is the severity and the amount of levator action there is. But we also have certain other points we get, such as lid lag. So you have to block out the frontalis action. This is really important. Often people sometimes do it so hard that they push the eye down, but actually you just need to block it out and then ask the patient to look down and look up. He's still trying to use it. I mean, he's a young kid, but that's basically what they do, and even adults tend to do that. So you have to be careful about doing that. Most people know that, but still we should be aware of it. Lid lag is when on down gaze, one eyelid lags behind the other. Often I find that residents also get confused between that and lag ophthalmos. So lid lag is very important because though it is a static sign, what it's indicating is that when you look down and there is a lag like this, that lag will remain post-surgery or worsen, especially in congenital ptosis. So you have to an LPS resection. So you have to point this out to the patients' parents, and let them know that post-surgery also there will be a lag, and which will get exacerbated post-surgery immediately. It may improve, but will always remain. So this is definitely a red flag. We have a lot of patients who come and say, no, but we went somewhere else and we were not told this. So actually that I think is not true. I make it a point to emphasize or overemphasize this. Also show photographs pre and post surgery. Coming to lag ophthalmos, when you close the eye, there's a little bit of lag ophthalmos. Again, this is something that you need to point out, because when you do surgery, especially in congenital ptosis, as was this girl, again the lag ophthalmos can worsen. Now she had a very mild lag off, so this is post-surgery actually, you can see the scar. It just worsened marginally, but this is not the case with all patients. So lid lag and lag ophthalmos is something you must evaluate. Margin crease distance basically the importance in congenital ptosis is that sometimes it's very faint and absent and gives an indication of the levator action. And in acquired ptosis, it's basically goes up or it's raised, and there's more amount of pretarsal show. Most patients actually who have acquired ptosis often complain of the ptosis, but the fact that they don't like the way the symmetry of the eye is looking. And this actually acts as your point of where you want to put your surgical line. Also, when you operate, a small thing is that as you operate, you also know as surgeons which way your scar sort of shifts depending on how you dissect your orbicularis. So in some patients, you will see a double elevator palsy, and you must check for this because you don't want to end up operating on a patient with a double elevator palsy. Coming to Bell's phenomena is something which we check, and this is exactly how you do it. You lift the eyelid up and ask the patient to gently close the eyes, and it's an upward and outward movement. But in certain cases, this reverses, which basically means it flips and goes upwards, outward, and inwards. That's fine as long as the cornea and eyeball is, having that upward movement. But there are a few incidents where the eyeball rotates downwards, and perverse is when it's moving in all directions. So when it's going downwards, what's important is that if you are going to do a ptosis correction and there's a significant amount of lid lag of ophthalmos, then that can be a problem for the cornea. So synchinectic ptosis is nothing but an aberrant regeneration of the trigeminal nerve with the external pterygoid muscle, so that when you basically your jaw muscles, as is seen in this boy, he has a ptotic eye, this eye goes up. So what is the importance of this? One is that there's an issue of ptosis and there's an issue of Marcus Gunn. So you can grade this. I really like this grading of Marcus Gunn. Mild is when the ptotic eye goes up by 2 millimeters on synkinesis. Moderate is when it goes up to the superior limbus, and severe is when there is superior scleral show. So mild, moderate, severe are important because they jump up. This is important because when you're correcting a Marcus Gunn ptosis, sometimes if a mild ptosis is there along with a mild Marcus Gunn, then when you correct it just by raising it, it dampens the effect, the amount of excursion that is going. So this is a girl who had a Marcus Gunn. So if you see this photo, you'd probably feel that, no, her pupillary axis is clear, we don't need to do anything. But she did have a progressive refractive error, that too in the form of a cylinder, and she used to drop her eye often. So though she's clenching and lifting it, the fact that she's dropping it often and has started developing a cylinder, to prevent further meridional amblyopia, we operated her. And that's how she is. She had a very poor levator action, and we decided to do a sling. So this is a red flag. Not every patient who comes. So you have to also catch them in their relaxed state. She's actually laughing here because we were trying to make her sort of comfortable. Herring's law is important in acquired ptosis a little more than congenital, because when this eye is ptotic, but when you lift it, what happens is, because of the common innervation to both the levators, because of the yoke effect, sometimes the unaffected eyelid drops. Now that is a very, very important test to do in acquired ptosis prior to surgery, especially in acquired ptosis in adults. In this case, the ptosis is corrected and this eyelid has dropped. Now this doesn't undo itself, so you need to check this before, because otherwise you have to go in and either bring this down, or in some cases in the literature, people end up correcting this. But usually people will never agree to correct the unaffected eyelid. So which basically means going back and putting this down. So this is not something like a Bell's phenomena, which sometimes gets altered post-ptosis and becomes normal. Schirmer's test is not so important as in congenital, but in acquired ptosis, it's something you must do, especially also now with refractive surgery and known cases of dryness post-refractive surgery. You should do it. If there is a significant amount of dryness, you need to inform the patients that there's a possibility of getting a little bit of SPKs and even some amount of keratitis. Finally, this is a patient. Oh, sorry, that my video is not there. Okay. So, oh, that was a video, sorry. So basically this was a patient, correct. So this was a patient who actually was a thyroid patient of mine. And you can see he has a slight asymmetry, which he never wanted to correct. And then he came to me and started complaining of this. Now you see what happens to the eyelid. It's very significant. He actually had a retraction. He was getting very confused because I was telling him to just. So basically what happens is the eyelid starts coming down. So in 48 to 50% of patients, you'll have a thyroid patient who starts developing a ptosis. As you can see here now, very clearly, see the pupillary axis is gone. So he had myasthenia. So these are some things that you should look out for and not end up operating thinking that they've got others, you're going to burn your fingers. So to summarize, a red flag is nothing but knowing the variations in the presentation of ptosis. Documentation and measurements are a must. I often get called sometimes, one or two plastic surgeons called me to operate and said, okay, come and help us in the OT. And I absolutely insist on seeing the patient before, and patient counseling with maybe photographs of how it would look post-operatively is worth it and required. Thank you. Should I introduce who's speaking? Who's speaking? So our next speaker is Dr. Rashmin Gandhi, who actually really needs no introduction. He heads the neuro-ophthalmology department at Center for Sight in Hyderabad, and is a phenomenal teacher and also a person.
Thank you, Sauri, for that very kind introduction. Thank you, Akshay, for inviting me to this instruction course. So my job is to weed out what are the neurological aspects of ptosis which one should look at in the practice, and why it is important to look at those aspects of neurological association of ptosis. Right. So why this is important? Now, this was a patient who was complaining of an acquired ptosis of the right eye. It didn't sound too well, so we advised him to wait for a while before we planned for surgery. He went for second opinion somewhere else, and he was operated upon on the right eye. And this is a post-operative picture around 2 months after surgery. You can see that actually the ptosis has increased. He has got a scar, and he has got a lid lag now on the down gaze. So any acquired ptosis associated with any of these neurological aspects, if it's operated upon, can lead to a disastrous result. And that's the reason why we need to rule out some of these associations. What are we worried about? Presence of myopathies. The reason why we are worried about myopathies is because they are progressive, and you will never get the desired results because the underlying pathology is not corrected. Nerve, which I would be concentrating on more, which will be a third nerve palsy and Horner syndrome. Myasthenia, which has been spoken about by Akshay and others. So let's look at this patient. So this is a patient who has a complete ptosis, a textbook picture of a third nerve palsy, has an exotropia. वो वहाँ पे प्ले नहीं कर रहा है, तो वो हाइपरलिंक करके रखा है। नहीं हाइपरलिंक करके रखा है। कनेक्टेड है, यहाँ तो प्ले कर रहा है। वो सीधा प्ले नहीं कर रहा है। ठीक है, छोड़ कोई बात नहीं। Yeah. So a complete ptosis with exotropia. What do we look for? Obviously, these patients you're not going to on ptosis, but what else you look for to make sure that you're not missing out on a neuralgic case? One is ocular motility to confirm that there is no elevation and depression. Second, look at the pupil to make sure that pupil is not involved. And the third is to make sure that the fourth nerve is functioning. And this is how you look at it. See, there is an intorsion when the patient looks from up to down. When there is an intorsion, you know that the fourth nerve is intact, and that tells you that this probably would be an isolated third nerve palsy without involvement of pupil. Now, why that is so important to know? So this is another example of a mild ptosis. This patient had a deficiency of elevation. Rest of the ocular movements were normal, but had a larger pupil on the affected side. So two different examples, one where the pupil was normal, the ocular motility showed third nerve palsy, and fourth was normal, while this patient had only limitation of elevation, rest of the movements were fine, and involvement of pupil. Now this is clearly a red flag that patient had a partial third nerve palsy. Why it's important to know? Because a partial third nerve palsy or a pupil which has a third nerve palsy which has involvement of pupil can be harboring aneurysm of posterior communicating artery. Why it is important to know? Because a death from ruptured aneurysm, 50% of these patients can actually, it can be fatal within 1 month, and all the survivors would have some amount of residual neurological defect. So this is an emergency. So first case, a third nerve palsy, involvement of pupil, or a partial third nerve palsy. Important caveat, rule of pupil does not apply to a partial third nerve palsy. If the patient has a partial third nerve palsy, he requires an investigation as if patient has an involvement of pupil. Case number 2, patient having a mild ptosis of the left side, and if you see here, there is an anisocoria which is worse in the dim light. In a dim light, the difference in the pupillary size is more than in a bright environment. And I would like to acknowledge Dr. Devendra, who gave me this photograph. So when there is a mild ptosis and an anisocoria which is worse in a dim light, you know that you're dealing with a sympathetic system problem. This patient had a mild left Horner syndrome. Now, why it is important to know about Horner syndrome? Acute onset painful Horner syndrome can be because of any of these causes. The important aspect is dissecting carotid aneurysm, which can present to you with Horner syndrome, and can present to us because patient would have a change in the appearance of the eye and patient would have headache. Now, in what circumstances patient would have dissecting carotid aneurysm? In most instances, it's a trauma to the neck. In older patient, it can be a trivial trauma. In a younger patient, generally it requires to be a severe trauma before patient has a dissecting carotid artery and presenting with Horner syndrome. Why it is important? Because these patients can end up developing stroke or MI, because the aneurysm, the dissection of carotid artery can throw up an embolus which can lodge in brain or in the heart. So in other words, pupil, Horner syndrome, third nerve palsy, migraine, RAPD, these are the association of pupil in patients with ptosis. What about ocular motility, other ocular motility? Again, the video is not playing, but the other important aspect to look at is myopathy. Myopathy would have a bilaterally symmetrical ptosis. Generally, CPO would present in ladies in first or second decade of life, while myotonic dystrophy would present in an older age group, and patient would have again a bilaterally symmetrical ptosis. Important aspect of CPO would be to look at ECG or echocardiogram, because these patients can have an associated heart block which can be fatal. So in summary, in patients with ptosis, any acquired ptosis, myasthenia has been stressed upon by both Savri and Akshay. Look at the pupil, smaller pupil on the side of ptosis, think of Horner's, make sure that anisocoria is looked upon in bright and dim light. Larger pupil on the side of ptosis, be very careful, that patient can be having partial third nerve palsy, and he will require, he or she will require MRI with MRA. In patient who has classical third nerve with pupil, sometimes even an interventional angiography can be required because the aneurysm can be fatal. So any acquired ptosis, beware of myasthenia or nerve involvement. I thank you once again, the whole team. Thank you.
Our next speaker is Dr. Tarjani Dave. She's a consultant at LV Prasad Eye Institute in Hyderabad, and she has been, let's say, a colleague, but has, I think, surpassed all of us now, and her presentations are something that I think all of us really look forward to, especially me.
Thank you, Savri. So from being Savri's student to here, it's a very, very good morning to hear that. All right, so I'm talking to you about red flags in oculoplasty on two specific conditions. One is thyroid eye disease, and second is invasive fungal sinusitis. So I'm going to speak about certain issues you see in both these conditions, which, like Savri mentioned, should raise a flag in your mind and might help you manage these patients in a much better way than you would otherwise have. So let's start with thyroid eye disease. We all know it has a very starey appearance. This is one classic patient of thyroid eye disease with a very congested orbit, and you can see that there's some amount of inflammation in both the eyes with this massive lower eyelid retraction on both the sides. You can see the prominence of the brow fat on both the sides, all of which are telltale signs of thyroid eye disease. This patient has been treated with steroids, and once you've done that, you see some amount of reduction in inflammation. So this is one of the classic presentations of an active thyroid eye disease. But what about this? So there's proptosis on the left side, which is very obvious, very, very massive proptosis. And he is actually a 53-year-old gentleman who's had this proptosis since 2007 and is stable. He's had sequential scans, again, which have been stable. And actually, these scans have been reported as him having a vascular malformation. So take a look at this. Clinical signs were very much like a thyroid eye disease, but look at the scan. It's very atypical. You don't see this kind of, shadows. You do see an enlarged superior rectus, probably a little enlargement of the medial rectus, but look at all these intraconal shadows. Very weird sort of a thing. And typically you see tent and belly both involved. So we thought probably it's a, it's a IOID and not a thyroid eye disease, and it might be good to consider a biopsy. So we opened him up, we did a biopsy in the same sitting. We also attempted a sclerotherapy because there was nothing to lose, and he'd already reported as a patient who has a vascular malformation. So we injected some bleo, we harvested some tissue. The tissue only demonstrated fibrofatty tissue, and we did multiple biopsies from multiple quadrants of the orbit, all of which demonstrated only fibrofatty tissue. So again, we were at a complete loss of what this really is. But what magically happened after the sclerotherapy is some amount of proptosis did reduce. His inflammation went down. We kept him under observation. He had some amount of residual proptosis, and he was very concerned with his appearance. So what exactly do you do in this kind of a situation? You can't go ahead and biopsy all this or remove all these tissues because they're so diffuse. You really can't do a good job there. So we went ahead and we did a decompression for him. So this actually, in my opinion, was a patient who had some amount of a vascular malformation in the orbit with an overlay of thyroid eye disease. And he had nothing else systemically, like a deranged, thyroid function test or any of the antibodies present, but just had this stable proptosis for some amount of time. Biopsy did not give us a clue. Eventually, he remained rehabilitated for over 2 years of follow-up after the decompression as well. So as of now, he's stable, but you do see these kind of cases where you are sort of, left in the middle and you don't know where, which direction to progress in. Just go by the clinical features and treat those clinical features. So I put this slide up to show you that if you see any patient with thyroid eye disease, you tend to see some amount of retraction of the eyelids. It could be the upper as well as the lower eyelid, or predominantly the lower eyelids, just a little bit of inferior scleral show. Any of those kind of features is what rings a bell about thyroid eye disease. But as has already been spoken in this course earlier by Savri as well as Dr. Rashmin Gandhi, ptosis is also a feature of thyroid eye disease. This is a lady who has bilateral aponeurotic ptosis along with proptosis. She has a systemic history of thyroid abnormality. These are her scans. You can see her enlarged muscles, and you see the eyeballs. They are practically, completely proptosed. And along with this proptosis, she also has a ptosis. So the largest component of ptosis in thyroid eye disease is actually the aponeurotic ptosis, where the aponeurosis probably stretches out or disinserts from the tarsus. But you also have a subgroup of patients with thyroid eye disease. Now, this is another lady. She has this temporal flare. She has a systemic thyroid abnormality who was kept under follow-up. And look at what happens 3 months later. She's come with drooping of both the eyelids. And when you do an eyes test, like Akshay so nicely demonstrated in his video, immediately you see an improvement in the ptosis. So this is myasthenia gravis associated with thyroid eye disease. It's been spoken so frequently in this course, and so many of us have seen, ptosis due to myasthenia in patients with thyroid. But if you look at the literature, then that percentage is around 5% of patients with thyroid eye disease who develop ptosis. So that's another sign that you should keep in mind. These are not patients you want to operate upon. And the third cause of ptosis in thyroid eye disease, probably the most important one, is compression at the apex. So this is a lady with photographs taken only 3 days apart. She has thyroid eye disease with a compromised cornea and ocular surface. And when you look at her 3 days later, she's come with ptosis. It's not just the eyelid inflammation. You see the inflammation here as well. But despite that inflammation, she has a progression in her ptosis. So what should you do? You should image. Why do you need to image? These are the patients who are actually developing compression at the apex. So that compression is affecting the third nerve, which is worsening the ptosis. It's not only the edema in the eyelid which is worsening the ptosis. In a patient who has corneal involvement, looking for dysthyroid optic neuropathy becomes difficult because vision and color vision are clues that you will not have. But scans will tell you that yes, there is compression happening at the apex, and we decompressed her medial walls, made the medial rectus move away from the optic nerve, and this is a clinical picture post-decompression. While the inflammation takes time to resolve, you can see that the ptosis has immediately sort of resolved. The second condition I wanted to talk about was fungal sinusitis, fungal cellulitis. So these are pictures of patients with cellulitis, some typical, some atypical, but essentially you would see a very inflamed red hot orbit in most of these patients who have cellulitis. But look at this. It's a quiet eye. You have a little bit of ptosis. This patient is post-COVID, 27-year-old, de novo diabetic, following steroid treatment given during COVID because he had a severity score of 12. And he develops diplopia. That's his only complaint, 3 weeks after recovering from COVID-19. If you look at him, he has restricted motility of the right eye outwards. So obviously you're wondering that he's developing some kind of a nerve paralysis, but this can be a big masquerade. We went ahead and imaged him because we were all in that heat of post-COVID mucormycosis, and imaging intuitively would come to mind. And when we did that, you see actually that his medial orbit and inferior orbit are involved. He had to undergo sinus debridement. This was a patient who actually had mucormycosis. So just a nerve paralysis, as the presenting sign of mucormycosis. So that's a red flag. You're better off picking the patient earlier and treating him faster. The other thing as far as cellulitis is concerned, and which I have learned from personal experience, is whenever you see this kind of maceration of skin, ulcerated skin, those are cases where you're more likely to get a fungal disease. And these are cases where I'd go all guns blazing, I'd give a PCR for fungus and do the entire diagnostic battery of tests that I have to make sure that this is a fungal disease. We did all of that. We did not find any fungus. We treated the patients with antibiotics. He did not respond. He had a sinus involvement as well. So I sent him to an ENT surgeon to debride the sinus. And once the sinuses were debrided, that actually picked up fungal filaments. So the orbital or the eyelid tissues did not show us any fungus. The sinus showed us fungus. We treated him with amphotericin B as well as itraconazole as a maintenance therapy. And this is him a couple of months later with complete resolution of that necrotic eyelid mass. The other situation is something like this, where this lady presents with just a 15-day history of blurred vision in the left eye. But if you look at her, this kind of hypoglobus is difficult to come up over 15 days, and there are these irregular nodules everywhere around the eye. We couldn't figure out what exactly we're dealing with, so we ordered for a scan, and this is how the scan looks. So your first thought would be that this is some form of a tumor, possibly a benign tumor arising from the bone. But if you just look at his scan, then there's expansion of the medullary cavity, and the maxillary sinus is completely obliterated on the other side, on the involved side. So we decided we'd go ahead with a biopsy, and when we did biopsy the bone and did special stains, we could pick up fungal filaments in this patient. So fungal disease need not present only as a soft tissue disease. You can have osteomyelitis of orbital bones, which typically presents with splaying of the bone or thickening of the bone on that side. And this is one more red flag that you should have in your mind. So she's been on treatment with antifungals. The nodules sort of reduce significantly, but the hypotropia persists. We've had to perform a tarsography to keep her cornea protected. Yet another case, when you see this sort of a discharging fistula, think of either a dermoid or a fungal cellulitis. In this patient, along with the discharging fistula, we had the picture of ophthalmoplegia. You see a complete ptosis over there. There was no motility of the eyes. So you should start thinking that there's something in the orbit more on lines of fungal disease. If I were to show only the scan, then probably the first thought that would come on to anybody's mind would be that this is a mass lesion producing, some amount of bone destruction. It's in the lacrimal gland region. Probably this is something like an adenoid cystic carcinoma, which tends to show perineural spread and have some amount of skip lesion. But all of this was just pure fungal disease, which responded very well with intraorbital injections of voriconazole. This was aspergillosis. Now, this is one picture. It's very old. This is, I think, is 2002. You can read on the scan over here. But just to tell you that fungal disease has always been there. It's not that mucormycosis is something that we're seeing only now. This was a patient with fungal disease and absolutely no sinus involvement. It's just apical involvement, for which quite frequently we tend to start steroids, assuming that this is Tolosa Hunt. And starting steroids in these kind of patients would be devastating. So it's always good to get some tissue for biopsy. In this particular patient, an endonasal biopsy was done. Tissue was procured from the apex without affecting the optic nerve and the vision. And this turned out as a fungal disease, and he was treated with antifungals. So just to conclude, whenever you see an immunocompromised patient with signs of ophthalmoplegia or some discharging sinuses or bony lesions, such as destruction of bone or hyperostosis of bone, suspect a fungal etiology and perform a workup accordingly. Thank you so much. Okay, so we have next Dr. Swati Kaliki, who is the head of the Operation Eyesight Universal Eye Cancer at LVPI Hyderabad. She'll be speaking on some tumors and masquerading diseases.
Sarojini, and a very good morning to all of you who are present here. In the interest of time, I will be quick and try to sum it up in 5 minutes, if possible. Okay, so the topic that was given was the systemic conditions with ocular tumors, the spectrum. I do not have any financial disclosures to make. So basically, I've divided them into the 4 segments, like the eyelid tumors, conjunctival, intraocular, and orbital. I'll probably take you through it very quickly. So this is a middle age patient who presented to the clinic with this thickening of the skin and discoloration of the skin, and it is very easy to make a diagnosis that this is a simple acanthosis nigricans. But the more important thing about this is not just making a diagnosis, but being aware that this can be a sign of occult gastric cancer. So it's very important to send this patient for a systemic examination so that we are not actually missing on the cancer, the dermatological condition can present before the cancer becomes evident. So always work up these patients appropriately. Then, of course, this is a common syndrome that probably many of you would have read in the textbooks, and rarely we do come across these in the clinics, the Muir-Torre syndrome. Here, the features are that they present with multiple sebaceous adenomas, the sebaceous carcinomas, and keratoacanthomas. And these, again, can precede visceral malignancy by 5 years, and mostly they present with colorectal carcinomas. And they have a different screening protocol that has to be followed in these cases whenever it is suspected, because you want to not miss the systemic malignancy and do all the investigations that are required to catch the disease early. And sometimes you can have multiple trichoepitheliomas. This can be associated with Cowden syndrome, where the patients can harbor breast carcinoma or thyroid carcinoma, and Carney's complex, where they can have multiple eyelid myxomas, or sometimes they can have just a single myxoma and can be associated with the cardiac, cutaneous, or the breast myxomas. And other very common condition that we see, that is the cutaneous periocular hemangioma. Now, when this is extensive, sometimes we see patients where almost half of the face is involved and they have lesions elsewhere in the body as well. Then in these conditions, it's very important to rule out if the child has Kasabach-Merritt syndrome, where it is the visceral hemangiomatosis, where the platelets are trapped and they can have severe thrombocytopenia and secondary coagulopathy, and it can lead to death, sudden death. So it's very important to work up these children. So if they have multiple lesions, large lesions, if they have hepatomegaly, if they have distended abdomen or petechiae that are present on the skin, always work them up for the systemic condition. This is again a straightforward case where plexiform neurofibromatosis that they can present with and can be associated with neurofibromatosis type 1. So always look for other tumors that may be present. And this again is a common thing, that's the nevus flemmeus, where a port wine stain would be present on one side of the face, that is associated with Sturge-Weber syndrome. Here we have to rule out secondary glaucoma, which is much more common, and of course the hemangioma. And these tend to have diffuse hemangiomas, which can be picked up on B-scan. I'll probably end with this last case for the eyelid tumors. That's the nevoid BCC, or the Golden-Gall syndrome that it is called. Commonly, it is an autosomal dominant syndrome which is associated with multiple basal cell carcinomas, and they have associated dyskeratotic palmar and plantar pitting with odontogenic keratosis. These, like here, you can see that one missing tooth of the patient, which is part of the syndrome. And this is mainly because of the mutation on the chromosome 9. So just to sum up the eyelid skin markers for systemic malignancy, the acanthosis nigricans can be associated with occult gastric cancers. Muir-Torre syndrome can be associated with visceral malignancy. Cowden syndrome can be associated with breast and thyroid carcinoma. Carney's complex can be associated with cardiac, cutaneous, and breast myxomas. The cutaneous capillary hemangioma can be associated with Kasabach-Merritt syndrome. Plexiform eyelid neurofibroma can be associated with the type 1 neurofibromatosis. Nevus flemmeus with Sturge-Weber syndrome and multiple basal cell carcinoma can be associated with the Golden-Gall syndrome or even xeroderma pigmentosum. So I think in the interest of time, I'll stop with the eyelid tumor. So hopefully I'll get to speak about the other tumors next time. Thank you.